Recording in progress.
Yes, and start.
Thank you. So good evening, everyone, and thank you for joining us tonight. My name is Arvind Hariram, and I am the medical manager with AstraZeneca Pharmaceuticals, responsible for the cardiovascular, renal, and metabolic portfolio. And it is my pleasure to officially welcome you to this meeting entitled Ramadan, Knowing Your Patient. This meeting is being endorsed by the Kenya Diabetes Study Group, as well as the Endocrine and Metabolism Society of Nigeria. First of all, I would like to say thank you to the faculty for accepting the invitation to participate in the program today. I know a lot of discussions have happened. I know there's been a lot of preparation to build the content for this very important topic. So we really look forward to the discussions tonight. Before I hand over to our chair for today, I would like to say a few words on behalf of AstraZeneca. So AstraZeneca is a global science-led, patient-focused pharmaceutical company. Our commitment is to improve the lives of millions of patients across Africa, together with our partners, with a focus on innovation, sustainability, and therapy area leadership. When we look at the cluster or the region that we belong to, which is Middle East and Africa, we have more than 2,300 employees over 33 different countries. And when we bring it down to the cluster that we involved in from an Africa cluster, which is made up of South Africa, Sub-Saharan Africa, as well as French-speaking Africa. We prioritize the health of our patients and to bring our life-changing medicines and working to ensure that every eligible person across the cluster, no matter the personal circumstance, can be connected with the right treatment. We work in partnerships with public and private sector entities across MEA to advance healthcare systems. And from a planet perspective, we push the boundaries of health and medicine in ways that respect the planet. And there's more to come in this area. When we look at AstraZeneca in terms of the therapeutic areas that we are involved in, I'm sure you're very much familiar that we're involved in respiratory and immunology, oncology, as well as the topic for today is around cardiovascular, renal, and metabolism. Cardiovascular, renal, metabolism diseases often coexist, and many patients have symptoms or underlying pathologies associated with more than one of these CVRM diseases. We are therefore focusing our efforts on the commonalities between these diseases and their underlying mechanisms to better understand how our portfolio might be used to address multiple risk factors or comorbidities, and where the combinations of medications might offer unique patient benefits. When we look at these four pillars, starting on the left, in terms of metabolism, we're looking to treat beyond HbA1c to prevent early cardiorenal complications and really explore in the area of NASH. From a heart failure perspective, to prevent and treat to eradicate one of the main killers in the world, and from a cardiovascular perspective, to reduce cardiovascular risk and slow disease progression. And finally, from a renal perspective, to treat life-threatening complications and halt disease progression. And we have agents that are being investigated in each one of these different areas. We have a very bold ambition, and that is to protect the lives of more than 130 million people with a strong continued commitment to new treatment options. So in conclusion, we are committed to continuous medical education. Forums like this, where you will be able to engage and learn much more from experts from different areas as well. We are committed to investing in R&D. And currently we have the CareMe registry, which is now being conducted in Ghana, Kenya, as well as Nigeria, with more than 600 patients enrolled in this program, looking at the burden of heart failure, type 2 diabetes, chronic kidney disease, as well as hypertension. We're advancing science through global comprehensive clinical programs, and you may be familiar with the DAPA Care program, which looks at investigating dapagliflozin in patients with or without type 2 diabetes and really looking at the cardiovascular and renal outcomes. And many of these studies, I'm sure you're very much familiar with. But ultimately, by doing all of this, we look to enhancing the standard of care to improve patient outcomes. So with that, I really hope that you enjoyed the program today. And it is my pleasure to now introduce to you the chairperson for today, which is Dr. Ahmed Reja. Dr. Reja is a consultant internist, diabetologist, and endocrinologist, an associate professor of medicine at the College of Health Sciences in Addis Ababa University. He's also the president of the Society for Endocrinology and Metabolism of Ethiopia, the chair of the NCD Alliance of Ethiopia, and honorary president of the Ethiopian Diabetes Association. So with that, I'll now pass it over to you, Dr. Reja. Welcome.
Thank you so much, Arvind, for that introduction. First of all, I would like to welcome you all to this important meeting on diabetes and Ramadan, knowing your patients. It's really an honor and a privilege to chair this important meeting. Thank you all for joining us this evening, and thank you AstraZeneca for organizing this important meeting. As you all know, fasting during the month of Ramadan is a religious obligation for all Muslims. Although the Islamic religion exempts people with chronic illness like diabetes from fasting, many Muslims nevertheless would like to fast. So as healthcare professionals, our obligation is to support our diabetic patients on safe fasting by modifying their treatments and medicine and lifestyles as necessary. So this evening we have lined up eminent speakers to talk on various aspects of diabetes and Ramadan. We'll have one presentation and 2 case studies. So if you have any questions, please put them in the chat box, which we'll be discussing at the end in the QA slot. So the first speaker is Dr. Sarabanu Sokwala. Dr. Sarabanu Sokwala is a consultant physician and endocrinologist, senior lecturer and associate program director, Department of Medicine, Aga Khan University Hospital, Nairobi. She worked with the Ministry of Medical Services from her internship to 2017, then as head of the Multidisciplinary Diabetes Care Center at MP Shah Hospital, Nairobi, till January 2022. Since then, she is working as full-time faculty at the Aga Khan University Hospital, Nairobi. She is executive member of Kenya Diabetes Study Group and an active member of CAP, Diabetes Kenya, and Kenya Association of Muslim Medical Practitioners. She has several publications, including book chapters in diabetes and endocrinology. She is passionate about diabetes education to patients, healthcare providers, and general public, and delivers this through various media and interactive platforms. She is a brand ambassador of the global patient education magazine, Diabetes. Her areas of interest include reproductive endocrinology, obesity, diabetes and sleep disorders, and diabetes and Ramadan. Dr. Sokwala is an eloquent speaker, and she's going to talk about patient perception about Ramadan and myth and facts about Ramadan. I hand over now to Dr. Sairabanu Sokwala to deliver her talk. Thank you.
Thank you so much, Professor Raja, for that elaborate introduction. And I'll share my slides, so please let me know if you can see them.
We can see them.
Yeah, it's clear? Good. So, Assalamu alaikum wa rahmatullahi wa barakatuh. May the peace and blessings of the Almighty be upon you all, and good evening or good afternoon, depending on which part of the world you are in. And we'll start with this talk, which although we have labeled it as myths and facts, it's all about the introduction to diabetes and Ramadan and the different aspects in a broad perspective. And then my colleagues will take us through the cases and the rest of the discussion. So just as a disclaimer, I think you can go through it for, just leave it there for about 10 seconds. So as an outline of my presentation, we'll be discussing, first of all, about the myths and facts and what are the common misconceptions. And then we'll look a bit at the benefits versus risks of Ramadan fasting in type 2 diabetes. We'll look a bit at the risk stratification and the tools that we have available for risk stratification. And then we go through the management and recommendations in Ramadan and fasting and touch a bit on the treatment aspects, especially as far as medication adjustments is concerned. So I'd like to acknowledge all the authors of the Diabetes and Ramadan Practical Guidelines 2021, because most of what I'll be discussing is actually extracted from those guidelines. So like Prof. Raja already said, in the Quran, there's Muslims are supposed to, like the Quran says, "O you who believe, fasting is prescribed to you as it was prescribed to those before you, so that you may attain self-restraint." However, it also says that whoever witnesses the month of Ramadan, then he or she should fast. But if any of you is ill or traveling, then he or she is exempted from fasting. So this is very clear that we are actually having some exemptions to fasting, and as much as it is highly recommended to fast, and illness is one of them. So these are some of the exemptions to fasting then. Children who have not yet attained puberty are actually exempt from fasting, but they still can fast, or if they choose to fast and they can safely do it, then it's not like it's a compulsory act on them. The sick, and the sick is where a group of our patients come in who have chronic illnesses like diabetes, chronic kidney disease, cardiac disease, and the like. And then travelers, women with menses, pregnancy or breastfeeding, and anyone with reduced mental capacity. So these are some of the exemptions. As we move on in the presentation, it's important for us to understand some of the terms that are used, which are associated with Ramadan fasting. So suhoor is this midnight meal that we have before fasting, which is between midnight to just before sunrise or dawn time. Then we have the iftar, which is the breakfast. So breakfast means the evening meal, which is usually taken at sunset. So the fast goes between sunrise to sunset. Then there is an 8 to 20 cycle prayer that happens only during Ramadan, which is known as Taraweeh. And this is usually conducted after the night prayer. And then after the month of Ramadan, there is a day of celebration, which is known as Eid ul-Fitr, where upon the sighting of the next crescent moon, the people who have fasted in the month of Ramadan actually are allowed to eat, and it's really a day of celebration with a lot of sweets and food and a lot of family gatherings and all that. So I'll just quickly touch on the myths and common misconceptions. There are many, but we will look at what is the most common ones and try to cover them in the subsequent slides. So there's a common myth that all people living with diabetes cannot fast. And that has been a myth for a while. Some people believe that everybody having diabetes is actually directly an indication that you cannot fast. But that is not always true. And this we shall see in our guideline and risk stratification tool, because the guideline gives us allowance because it was established in collaboration with the muftis and with the medical practitioners. And it does give us allowance for a category of people who can actually fast if they're living with diabetes. And that is why it's important to do the risk stratification. How about this fact? Now, the opposite of what I've just said is all adults, regardless of having diabetes, must fast. And this is even more common in our part of the world and in most Muslim countries because of the fact that fasting is one of the pillars of Islam or one of the pillars of the religion. Then it is like thought that whatever the condition you have to fast. And that's why, like what Professor was saying is that people still do insist on fasting, even if they fall in moderate or high risk categories. But the conception that whatever the condition that you have, you must fast, that is actually a myth, and that we need to break to the patient. And when we talk about figures, patients understand better. You say that, okay, look, we'll do your risk calculation, and this is the category that you fall in, and then advise them whether they can or cannot fast, as we shall see. There's another myth or misconception that insulin injection is not allowed in Ramadan, and this a lot of patients would tell you. And so that is not true, especially not in the fasting hours, and anyway during, in the eating hours, and either way during the fasting hours, insulin is hardly injected because that's the time you're not feeding, so you're not going to inject insulin at that time either way. How about this fact about people living with diabetes should not eat suhoor? And this is a common thing that some of my patients come and ask me. And of course, that's not true. If anything, they should try to eat their suhoor as latest as possible, close to the dawn prayer, and eat, as we shall discuss, the complex type of carbohydrates at that time. The other conception that we have is blood glucose monitoring breaks the fast. And this also, and in we shall see, actually a 7-point monitoring is recommended during the fasting hours, and that we should tell our patients that no, that's not true, and that's just a myth, and you can monitor your sugars safely. How about injected glucose breaking the fast? Again, this is a question you're asked. Oh, my sugar is going low. If I use injected insulin, injected glucose, is that going to break my fast? Obviously, that is going to break your fast because that's a nutrient you're injecting into your circulation. So that is going to break your fast. And the aspect of people living with diabetes should reduce their medication in Ramadan. And we see this quite commonly, people deciding to fast, they are coming in hyperglycemia or even DKA with type 1 diabetes, where they just decide because they are fasting, they are going to reduce their medication. So yes, there is the whole concept of medication adjustments, but not necessarily reducing or stopping their medication. And that's what we need to educate them on. And then the whole other concept of people living with diabetes should eat more than those without diabetes. And this is going to be discussed a little bit also in my presentation to see what it is that the basic recommendations are as Ramadan is concerned. So, to answer most of these myths and misconceptions, the rest of my presentation will hopefully attempt to answer most of the questions that we have raised. So then we will first look at what are the benefits and the risks of fasting when you have type 2 diabetes. So just quickly to take us through the physiology of feeding and fasting in healthy individuals so that we understand what is it that's happening in fasting and diabetes patients. So when you look at healthy individuals, when you eat food, you get glucose into the circulation. And the first thing that happens is you get insulin secretion. And what does insulin secretion do? It stimulates glycogen store formation and it inhibits gluconeogenesis, right? So that's the work of insulin. So that you actually use up your glucose to get energy, and the remaining glucose is then stored as glycogen. Now, in healthy cases, when you are fasting, then when you don't get glucose, what happens? The first response to hypoglycemia or low sugar in the blood is actually reduction in insulin secretion. So there's a reduction in insulin secretion, and that stimulates gluconeogenesis, and then that actually produces glucose to be delivered to the muscles and inhibits glycogen deposition. And actually, if it's prolonged, then it can stimulate glycogen breakdown so that you get glucose in the circulation or glucose for energy use. So what about when you are fasting and you have diabetes? Now we know that when you have diabetes, you have impaired insulin secretion or absent insulin, or you have got insulin resistance. So now when you take in food, and when you don't take food and there's no glucose, then the issue that you should actually have, the first response, like we said, is reduction in insulin secretion. But here already your insulin secretion is quite decreased, or there is resistance. So there's a deficiency of insulin. So there's an excessive response that can happen with increased gluconeogenesis. And because there's no insulin, there's an increased release of your counter-regulatory hormones, which promotes gluconeogenesis as well. And that also quickly uses up the glucose that is available for your muscles. And like about 12 hours into fasting, then your body ideally supposed to go in the ketogenic phase. But when you don't have insulin, then this ketogenesis is much faster, especially in patients who have type 1 diabetes. And that is why there's an increased risk in these individuals. So there are benefits and there are risks when a patient with diabetes is fasting in Ramadan. And generally looking at the lifestyle, physical and mental benefits during Ramadan, before I discuss this, I'd like to say that fasting, even including intermittent fasting, is a form of autophagy. And autophagy just means your body going like as if you have clicked the reset button, and there's regeneration of the unwanted cells, if I could put it that way, so that you get modification or rather recycling of your body cells which are damaged. And that is one concept that is there in all forms of fasting. So it has its benefits. So let's look at a bit of the changes that occur and with benefits and risks. So when you look at lifestyle changes occurring when you're fasting, you have a change in your sleeping schedules, which could be both positive and negative because of the timings that different individuals sleep and wake up. Then the meal plans and diets are changed, obviously. Physical activity patterns are disrupted because there's of the fasting activity. I mean, the fasting times, it's a bit difficult to do a vigorous physical activity. And we'll look at this in a while. There's one advantage that you get because you're not supposed to smoke. So other than refraining from food, you're supposed to refrain from other vices like smoking. So that helps us to kind of assist us to probably see if we can, our patients can stop smoking, and could be used as one of the methods to try and stop smoking at that time. And then there's a lot of medication adjustments that take place. How about the effects on the physical and mental benefits? So there's a sense of fulfillment religiously and spiritually when you're fasting. If you do it correctly with the right kind of diet and physical activity, then you could get an improvement in weight or BMI, and several studies do support this. Although some in certain parts of the world, depending on the type of diets, are showing a bit of controversial results. But most of the meta-analyses are now showing that there could be benefit if it is done correctly. And then improvements in self-control and ability to resist temptations overall, greater sense of sympathy and empathy, because this month is actually considered the month of giving. There's a lot of charitable activities that take place in this month. So it also creates a sense of societal fulfillment as well. There's participation in other spiritual activities, as we have talked about. And then when you look at the potential adverse physical and mental effects, then as I said, you could have sleep deprivation and disruption of your circadian rhythm. And this could lead to increased fatigue and reduction in cognition, especially in the first few days of fasting. But as you continue fasting, this kind of abates or reduces. And then you could get glucose excursion, which causes the feelings of being a bit unwell, lethargic feelings at times, fear for diabetic-related complications, and these weight changes, and sometimes a temporary feelings of anxiety, which are usually as well in the beginning months. So if you summarize, then the risks that you're looking at with diabetes and fasting, one of them, like we talked about, is diabetic ketoacidosis, especially in insulinopenic patients. And that is why this category has been put in the risk stratification tool, as we shall see. Hypoglycemia, especially during the fasting periods in patients who are on secretagogues or who are on insulin itself. And hyperglycemia can occur as well because of the deranged metabolism, and you can get dehydration and a higher risk of thrombosis, as has been shown in certain studies. So then when we look at the benefits and risks, then there is this whole aspect of pre-Ramadan assessment and risk stratification. So this is what is beautifully recommended in the guidelines. And I really like this slide because it summarizes everything about what we talk about with pre-Ramadan, Ramadan, and post-Ramadan assessments. So all individuals seeking to fast should ideally attend a pre-Ramadan visit 6 to 8 weeks before Ramadan. And already we know we are into 1 week, we are just having 1 week into Ramadan, but again, it's never too late. You still need to continue doing this risk stratification. And I'll show you what tool you're going to use for the risk stratification. And with risk stratification, there's the aspect of pre-Ramadan diabetes structured education. And you first have to look at all these features where you take a detailed medical history, look at the aspects of diabetes and the ability of self-management, look at what comorbidities these patients have. Are they mentally capacitated? Do they have hypertension? Do they have chronic kidney disease? What other conditions are they living with? The individual's prior experience, that's also very important of managing diabetes during Ramadan, and the ability to self-manage, especially as relates to self-monitoring of blood glucose and dose adjustments, and the other aspects increasing the risk of fasting, like higher risks of dehydration, kind of work, where they're living, and all that information. And then you do this risk stratification into low, moderate, and high. I'm not focusing right now on the structured education because we look at that step by step. So after you have done your risk stratification and you put your patient into low, moderate, or high risk, now let's say the patients are going to fast. Then you need to teach them about self-monitoring of blood glucose, and that is based on the risk stratification tool. And that is a 7-point monitoring, as we shall see, but it has to be individualized. So all individuals should break their fast in Ramadan. If their sugar is going below 3.9 and at any point below 3.9, then they need to just break their fast. And they should recheck their sugar. And if it's still persistently low, then definitely they have to break their fast. If their glucose levels are also going above 16.6, then they have to break their fast. Or if what I tell them is whatever illness you have, just break your fast. If you feel unwell, please break your fast, check your sugars, break your fast, have something to eat, and get yourself assessed if need be. And then this is a very important aspect that we forget often, is the post-Ramadan assessment. So we have managed our patients very well. We've supported them through Ramadan. After Ramadan, you need to do a post-Ramadan assessment and note it down, document it in your notes to see how their Ramadan experience was. And this could guide you in the future as well. So these are the risk factors that may influence the development of this personalized care. And most of these are the factors that have been considered in developing the Ramadan risk stratification tool. And you have to look at Ramadan-related factors, diabetes-related factors, and factors related to the individual. Like the length of the fasting hours, what time are they fasting, the season of fasting. You know, fasting every year, you are moving ahead by about 11 to 12 days. So that's what has to be kept in consideration. The weather at that time, geographical location, social changes, and the past experiences as already talked about. And then the type of diabetes and its duration, any complications related to diabetes, what are the drugs that the patients are on, how has the previous control been, what is the HbA1c, what is the time in range for those who are using CGMs, what are the, what is the risk of developing hypoglycemia, how well are they accessible to you or to receive care? And then looking at the individual factors is like the age of the patient, because elderly especially are at high risk of some of these complications. So that has to be kept in consideration. Gender, occupation, pregnancy and lactation, meal patterns, and these other factors. So then based on that, you have this risk quantification of these are the areas of pre-Ramadan assessment that we are looking at and components of a focused educational program. And we look at risk quantification first of all, and we look at each one separately. So the first aspect we look at is risk quantification and exemptions and removing misconceptions. So there's this amazing tool that has been created, which has been very objective and helps us to risk stratify our patients. It's easily available, free of cost, online for all of us to access. And you put in information like duration of diabetes, type of diabetes and duration of diabetes, and you do the scoring accordingly. Hypoglycemic symptoms, whether they have HbA1cs within target range or not. Do they do self-monitoring? Are they motivated to do self-monitoring? What acute complications have they had in the last 3 months? Chronic complications, that also like chronic kidney disease and cardiac disease, especially cardiovascular disease. Pregnancy also scores highly. Frailty, physical labor, previous Ramadan experience, fasting hours, and the type of treatment. And you can see that the basal bolus and the insulin infusions are at a higher risk category than, let us say, for example, lifestyle modification or using only metformin or not on sulfonylurea or DPP-4 inhibitors. Then the risk of hypoglycemia is low. So you click all this information and you basically get the score. So if your score is 0 to 3, you are considered at a low risk for complications with diabetes. If your risk score is between 3.5 to 6, then you're at moderate risk. And if you score more than 6, then you are at high risk. So what do these scores mean? So when you're at low risk, then the medical recommendation is that fasting is safe. And the religious recommendation is at this point, then fasting is obligatory. And the advice not to fast is not allowed unless the patient is unable to fast due to the other conditions like physical burden of fasting or needing to take medication or food or drink during the fasting hours, probably due to other reasons. And when your patients are at moderate risk, then the medical recommendation is that you do medical evaluation, you do your adjustment of your doses, and you have to ensure that the patient is doing strict monitoring. If they're going to agree to do all these things, and you know that they're motivated and they're able to do that, then you need to support them through the fasting. How about with religious? So they say that fasting is preferred, but patients may choose not to fast if they are concerned about their health after consulting the doctor and taking into account the full medical circumstances and their own previous experiences. And if the patients fast, then they must follow medical recommendations, including especially blood glucose monitoring. And both the medical and religious recommendation are against fasting if you are at high risk. And that is what, if we talk to the patients, so when my patients come, they say, no, you know what, I have to fast. But when you sit with them, you talk to them, you say, look, there's a tool we can use. And this is the category you fall into. You fall into a very high risk category. And they still insist, no, but I still want to fast. You don't shoo them away from your facility or from your clinic. You actually still have to support them through their fasting. And one good thing or one advice that we can give them is to do test fasting. So just before Ramadan, you can tell them to fast for 1 or 2 days and you see how the experience is going to be, and they'll understand for themselves if why or they should or they should not fast. And then you can probably space out the fasts, allow them to fast probably in the last few days, and you can agree with the patient on how you want to go about it. Then the aspect of blood glucose monitoring. So this is the 7 points that we talk about. So first is the pre-dawn meal, that is before suhoor. And the second one is in the morning about 10 a.m. The third one is midday. The fourth one is mid-afternoon. The fifth one, and I believe this is one of the most important times to check, is before iftar. So this is like your fasting glucose. And then 2 hours after iftar, and at any time that there are symptoms of hypoglycemia, hyperglycemia, or feeling of being unwell. So that's the timing that is recommended. And this is variable. This is individualized. So if a patient is having type 2 diabetes, they're only on metformin, they are only on probably low glucose, low potential of hypoglycemia, then you can tell them to monitor at least 2 or 3 times based on what they can do. And if they are on multiple daily insulin injections and they are fasting, then you definitely need to advise them to do at least 5 to 6 readings in a day. So having the skills to self-monitor glucose can empower patients with diabetes to effectively self-manage their disease. And I can really not overemphasize this, because this is the most important aspect if your patient is insisting on fasting, especially in the moderate and high-risk categories. How about fluid and dietary advice? As you can see, this is the type of food that is widely available, and I believe not only in Kenya, but across most of the countries that we are in. And these are high caloric, high carbohydrate, high glycemic index foods, which are available all over the place. And that is what our patients prefer to eat in Ramadan. And you can see this is in a coastal place of Kenya. You can see all these amazing foods available. But that is what we have to advise our patients to limit. And then dates. So a lot of patients also, amongst one of the misconceptions or myths, is that dates are healthy, and dates, even whatever amount you eat, is not an issue. But we can advise our patients to have 1 date to break their fast and probably 1 more date at suhoor time, but ideally avoid more than that, especially if the sugars are on the higher side. So the recommendation is to divide the calories between suhoor and iftar, plus 1 or 2 snacks if necessary. You ensure the meals are well balanced. Recommendation is that 45 to 50% should be your complex carbohydrates, and these are the examples. % should be proteins, and less than 35% should ideally be fat, preferably mono and poly, and avoid unsaturated fats. And you choose foods that are with low glycemic index, high fiber foods that release energy slowly before and after fasting, like the examples given, and include plenty of fruit. Now, fruit here you have to be cautious, because depending on where you are and the type of fruits that are available, like fruits, like if you're looking at, mangoes and oranges, and we've got very sweet fruits, sometimes watermelon, those should be restricted. I'm not saying avoided, but probably at a smaller portions than if you're like, let's say, eating blueberries or raspberries, which would have a lower glycemic index, and a lower load of sugars. Vegetables should be encouraged. Minimize foods that are high in saturated fats, like the foods that I've just shown you. Avoid sugary desserts. Use small amounts of oil and use the type of oil that would not really impact a lot. And hydration is very key, especially for our patients who are on SGLT2 inhibitors. Tell them to keep hydrated between the during the eating times and avoid caffeinated drinks, right? And complex carbs, like I said, are recommended for the suhoor meal, while if you're taking simple carbs, then for the iftar meal. And then we look at physical activity. So exercise in Ramadan, one thing we know is rigorous exercise should be avoided during the fasting hours because of your increased risk of hypoglycemia and dehydration. But people living with diabetes should still be encouraged to maintain their normal physical activity, and this can be considered during the feeding times. And you have to tell them that the Taraweeh prayer, it's quite an intense prayer. It's 8 to 20 cycles, and that should be considered as part of their daily physical activity. And they are more likely to achieve good A1C targets when they are more involved in this kind of nightly prayers. And there are many nightly prayers other than the Taraweeh prayer. And so this is also what Ramadan looks like in our part of the world and most of the Muslim communities. So when to break the fast, I think we have already discussed this. I'll not dwell on this. Hypoglycemic symptoms, you have to teach them, and hyperglycemic, and tell them that when they feel those symptoms, they need to quickly check their sugar, and if they can't get access to that, they need to break their fast. So I'll touch only on a bit of the medication adjustment for type 2 diabetes in Ramadan, and acknowledgements to the chapter lead and to the authors of chapter 10, which discusses this aspect. So when we look at metformin, because that's one of the most commonly used drugs during for type 2 diabetes, then how do you adjust? The truth is, one thing you tell your patients is that breakfast is now iftar. If you just explain that to them, that when you're breaking your fast, that's the time you take your morning medication, and when you're starting to fast at suhoor time, that's the time you take your evening dose, and where adjustments are needed, you do them accordingly. So what does that mean? That if you're on metformin once a day, then no dose modification is required. So one thing to remember with metformin, total dose, you don't need to usually modify it. But if they're taking it once a day, then you just move it to the breakfast time, that is the iftar time. Twice daily dosing, you don't have to adjust. You just take at iftar and suhoor. 3 times daily dosing, you'll take the morning dose before suhoor, and you'll combine the afternoon dose with the dose taken at iftar, and they take that dose at iftar time. And then the prolonged release metformin, you don't need to change, but you take it at iftar time. And when we look at the other medication, when we look at thiazolidinediones and especially pioglitazone, then again, you don't need to do dose modification, but dose should be taken again with iftar. Like simple rule is iftar is breakfast, right? So fasting. How about ripaglinide and nataglinide, which are insulin secretagogues? So if your patient was on a 3-meal dosing, this may be reduced or redistributed to 2 doses during Ramadan according to the meal sizes, right? That is with iftar and suhoor. GLP-1 receptor agonists. So the GLP-1 receptor agonists, you ideally should have started them at least 2 to 4 weeks before Ramadan and done the dose titration accordingly based on what you're supposed to do, and avoid dose titrations during Ramadan or initiating it during Ramadan. However, whatever dose they were on, you don't really need to do treatment modification, preferably move it to iftar time. How about DPP-4 inhibitors? Really, because of the low risk of hypoglycemia, they do not require treatment modification. If they were taking like once a day, let's say linagliptin or teneligliptin, you can move it to the iftar time. But otherwise, if you're taking twice a day, they take it at suhoor and iftar. SGLT2 inhibitors, an important category of drugs, and I get a lot of questions asked about this. They have a low risk of hypoglycemia, no doubt, and they do not need dose adjustment. But please remember, tell your patients to take it at iftar time, do adequate hydration, and if they are feeling unwell, their sugars are, fluctuating, or they are feeling symptoms of dehydration, then they need to check for ketones or come to the hospital. They need to break their fast and probably be aware of the risk of ketoacidosis, which is the euglycemic ketoacidosis. So that's very important to educate your patients on, okay? Acarbose, it's not commonly used in our country, but you do not need to do dose modification if you're using it. So pio, we already talked about. How about insulin, which is another topic which confuses people. So if you are on a once daily dosing, before insulin is a sulfonylurea. So if you're on a once daily dosing of sulfonylurea, you just move it to iftar time. But individuals who are well-controlled blood glucose, you might want to reduce your dose of the sulfonylurea to a half of the dose that they are taking. If they are on twice daily dosing, then the iftar dose remains the same. If you have good sugar control, then the suhoor dose should be reduced and preferably even stop. Sugars are very well controlled, especially you'll know in the first 2-3 days of Ramadan. But all the drugs ideally are not recommended to be used, like glibenclamide. You have to avoid using it because it's a high risk of hypoglycemia. You switch them preferably to a newer generation like gliclazide, modified release, or glimepiride instead of glibenclamide. And then insulin, again, actually the rules are very simple if you actually look at it. So if your patient is only on an OD or a once-a-day insulin dosing and it's long or intermediate acting, then you just have to reduce the dose by 15 to 30% and take it at iftar time. If you're on a twice daily dosing, then that has to be, the usual dose is taken at iftar, but the evening dose is reduced by 50% and taken at suhoor time. What about short-acting insulin? The normal dose is taken at iftar. You'll omit your lunchtime dose and reduce the suhoor dose by 25 to 50%. Can you hear me?
We can hear you.
Yes.
Yes, okay. We just had a blackout for a second, but we are back. So, and then the lower tables again is teaching us about dose modification or adjustments based on the glucose level. So you have to tell the patient accordingly how they can reduce or increase their doses based on the sugar levels before and after suhoor and iftar. How about if you're on a mixed insulin? So if you're on a mixed insulin once a day, then again you just move dose at iftar time, twice daily iftar and suhoor, but the suhoor dose you're going to reduce it because after this the patient is. Then if they're 3 times daily dosing, you omit the afternoon dose because you're not going to be feeding, and you adjust the iftar and suhoor doses, and you do dose titration every 2 to 3 days. And that is basically it. And you look at the insulin pump dosing, it's just that during the fasting hours, over the last 3 to 4 hours, you reduce the infusion basal rate by 20 to 40%. And then if during, like just after iftar, again, you increase it by about 0 to 20% and you do those adjustments with the patient. But bolus rate has to be based on the normal carb counting and insulin sensitivity ratios. So what are our take-home then messages from this presentation is that structured diabetes education find it easily online, and from Play Store you can advise your patients, and we've been doing a lot of this for our patients this Ramadan, to download this app, Safa app, Diabetes and Ramadan Safe Fasting, and it really has crucial important information for the patients. And then that's the end of my presentation. Ramadan Kareem to all of you. Thank you very much.
Thank you, Dr. Sarah Sakwala, for this clear presentations on assessment, the risks, advising pre-Ramadan, during Ramadan and post-Ramadan. I'm not going to summarize this well-elaborate talk. So if members have questions, please put them in the Q&A box. Then we'll raise those questions. So next, we have the first case study, which will be presented by Professor Aishatu Nalado. Professor Aishatu Nalado, she is Professor of Medicine and Consultant Nephrologist at the Department of Medicine, Aminu Kano Teaching Hospital, Lecturer, Faculty of Clinical Sciences, College of Health Sciences, Bayero University, Kano, Nigeria. So Professor Aishatu Nalado will take us through the first case study about fasting CKD patients with and without type 2 diabetes. Professor Aisha.
Thank you for giving me the opportunity to present. Today, my topic of presentation is management of diabetes and kidney disease during Ramadan, knowing your patients. I'm sorry, I think I'm having some connection problem. So this is my disclaimer. This presentation is intended for educational purpose only and does not reflect what AstraZeneca has in position, and the slides are my own slide and not from AstraZeneca. This is the outline of my presentation for today. I'll go for introduction, risks associated with diabetes in people living with diabetic kidney disease, risk stratification, pre-Ramadan, Ramadan and fasting, medical management of type 2 DM and chronic kidney disease during Ramadan, case studies, and then I conclude. During Ramadan, the period of fasting extends from dawn to dusk. Fasting Muslims are expected to refrain from eating and drinking, as discussed by the first speaker, so I will not dwell much on this presentation, but just remind you that the period from dawn to sunset varies depending on location and season. Fasting is mandatory for all Muslim adults with certain groups exempts, including some people with chronic conditions like diabetes, kidney disease. Despite potentially being exemption, many people with diabetes will choose to fast. This is just an estimate that suggests over 150 million Muslims with diabetes worldwide are available, and therefore Ramadan has a major impact on the management of diabetes in Muslim population. Due to the metabolic nature of the condition, people with diabetes and kidney disease are at particular risk of complications from marked changes in food and liquid intake. I will not dwell on it, just to show you that there's an increase in the number of people living with diabetes worldwide, and it is estimated that about 537 million people are living with diabetes by the year 2021, and this is proposed to increase by 46% from 2021 to 2045, rising to a number of 784 million. So this will show you that there's going to be a pandemic of diabetes, especially in sub-Saharan Africa. In sub-Saharan Africa, it will increase by 129%. There will be an increase by 2045 in people living with diabetes. We know the adverse complications of diabetes. They cause kidney injury, stroke, myocardial infarction, hospitalization, progression of the disease to chronic kidney disease, which will end up in dialysis or transplantation, heart failure, and eventually the patient may die. Global prevalence of CKD, more than 850 million people are living with chronic kidney disease, and it is estimated that women are more at risk of developing chronic kidney disease with a percent of 11.8% as compared to 10.4% in men. Key risks associated with Ramadan fasting in patients with diabetes have extensively been discussed by the speaker earlier on, but we know that there's increased risk of hypoglycemia, hyperglycemia, diabetic ketoacidosis, and dehydration and thrombosis. Ramadan focused education has extensively been discussed by the earlier speaker, but I would just like to highlight you on some important parts that involve patients with chronic kidney disease. It is important to sit down with patients with chronic kidney disease and educate them on their disease and the risk of Ramadan. So you empower patients with the knowledge needed to make an informed decision. Then you give them the components of Ramadan focused education. You advise on exercise, knowing when to break the patient, when the patient should break his fast or her fast. And then patient must be assessed at least once weekly, and patient must be aware of symptoms of an increased weight, shortness of breath, anorexia, swelling, edema, or weakness when the serum creatinine is greater than 30% from baseline. There should be adjustment of medication and post-Ramadan follow-up. This is Diabetes and Ramadan International Prospective Study. I will not dwell much on it, but just to show you from the GREAT study, it showed that people that have hypoglycemia before Ramadan were 5.4%, and those that had hypoglycemia during the Ramadan period were 8.8%. This is showing you that there's increased risk of hypoglycemia in diabetic patients. This is a summary of a table showing you studies and researches that have conducted on people that have chronic kidney disease and were fasting. In a study by Brogazi in 2015, he noticed that people who had reduced EGFR, that is glomerular filtration rate, compared to those that fast and those that did not fast. What he concluded was that cold weather does not really improve EGFR, because whether it was during hot season or during cold season, there was really no impact on reduction of glomerular filtration rate. But they concluded by saying more studies were required as their sample size were only 15 patients. In another study by El-Wakil, he found no significant difference in the reduction of EGFR between patients that fasted with CKD and those that did not have CKD. But they noticed increase in tubular markers in urine. The tubular markers are those suggesting whether there's increase in proteinuria in patients that fasted, but they suggested that a large prospective study was needed for further recommendation. In another study by El Mohana, the EGFR was reduced in both patients that fasted and those that did not fast, but they found that there was a reduction in EGFR more in the fasting group, but they said large control prospective studies were needed for us to have a conclusion. In another study that had a larger sample size by Nasser and Usman, they found that patients with reduced EGFR, they had increased risk of CKD deterioration with significant increase of serum creatinine in those that fasted. But they noticed that the deterioration was possibly not due to the fasting, but possibly due to disease progression in patients that had chronic kidney disease. So these are some of the researches that showed people that fasted and people that did not fast in stage 2, 3, and stage 4 of CKD. There was no fasting, did not really have a remarkable effect, but all the studies had a minimum sample size, hence larger prospective studies were needed to conclude the finding. Similarly, in patients that had transplantation and tried to fast, a meta-analysis by Bragazi in 2014 reviewed them. After review, a patient that had transplantation and fasted and those that did not have transplantation. At the end, there was no effect on those that had transplantation on the EGFR, and they were able to pass. In a similar study by Galbraith et al., 35 patients were monitored and they had EGFR and proteinuria. They were not different from those that did not have transplantation and fasted, so they were all able to fast. So to conclude is to say that many patients that had kidney transplantation were able to fast, and hence there was no side effect after fasting if patients had kidney transplantation. But in another group of patients that were either on peritoneal dialysis or hemodialysis, study by Alweki showed that patients that had hemodialysis, were on hemodialysis, had hypernatremia and hyperkalemia, but they did not require hospitalization. Another study by Elwaki et al. In patients that had peritoneal dialysis, there was no effect from fasting and they were able to fast during the period of Ramadan. In another study of patients who had hemodialysis, there was no significant effect on their weight, blood pressure, or serum potassium, and so they were able to fast. The only group that had problem was the study conducted by Adnan et al., where patients that were on chronic hemodialysis and they fasted, they noticed they had improved intradialytic serum phosphorus creatinine weight, but albumin was decreased. The participant, although in their study, there was a limitation because they were the young age group and they needed close monitoring. What the effect of mortality was tried on patients that found that there was higher mortality in patients that fasted and were on hemodialysis. But the deaths in conclusion was that it could be due to other comorbid conditions and does not really necessitate that the mortality was caused due to the patient fasting who were on hemodialysis. She has already extensively discussed the categories of risk in patients with diabetic and kidney disease who fast during Ramadan. We have very high risk, we have high risk, we have moderate risk, and we have low risk, which I will not go into because the speaker has extensively discussed this risk. There was a study conducted last year in June. Over a period of 6 months, patients in the United States were subjected to fasting when they had kidney disease. In the proof, at the end of the study, they concluded no marked difference between patients that had kidney and those that did not have, that had kidney disease and did not fast. Kidney disease could fast, but you have to make sure that they take a lot of food and avoid dehydration in such patients. This is health issues related to nutrition during Ramadan, which she has extensively discussed, and I will not dwell on it, but just to remind you that this diets that we take large meals of calories, high carbohydrate diet, sugary desserts, and eating too quickly during iftar or sahur predispose us to either hyperglycemia, hypoglycemia, or dehydration. The medical management recommended that SGLT2 inhibitors were recommended. The results of this study have prompted several diabetes and Ramadan experts to reconsider the current recommendation for the use of SGLT during Ramadan. These studies indicate the following recommendation. For stabilization, SGLT2 inhibitors should be initiated at least 2 weeks to 1 month prior to Ramadan, and SGLT2 inhibitors are recommended to be administered at the time of the evening meals iftar. But you have to consider telling your patients to increase fluid intake during the non-fasting hours of Ramadan. The International Diabetic Federation and the Diabetes and Ramadan guideline recommendation for patients with chronic kidney disease, end-stage renal disease, and renal transplantation. There was really not much guidelines. They did not say much about patients with chronic kidney disease, as they have described well in patients with diabetes. But the take-home message is that most of these patients were in a small sample size, and we needed larger sample size and more prospective studies to conclude the guidelines and the recommendation. But Ramadan fasting is permissible in persons with stable chronic kidney disease. Those with CKD stage 1 and 2 should be allowed to fast, and those who have undergone kidney transplantation, and those that have just a temporary deterioration in their biochemical abnormalities. During Ramadan, patients who have received kidney transplant or have stage 3 to 5 chronic kidney disease, we should remember are at higher risk of worsening of the disease and are hence advised not to fast. The guidelines recommend that more considerable prospective studies, including randomized controlled trials and studies examining the effect of fasting on vascular tissues in patients with diabetes and other comorbidities, are necessary. They suggested a risk stratification and patient management method, enabling patient-centric conversation to secure a safe Ramadan fasting. This is to start my main topic of the day, which is case study. I have a patient that I personally manage, who is a 68-year-old male patient with type 2 diabetes for 20 years and CKD for 5 years on regular treatment, and wanted to fast during Ramadan in 2022. The patient has never had an issue with hypoglycemia. His body mass index, BMI, which he has worked hard to reduce from 35 kg over the last 2 years, was 28. His sugar and CKD is well controlled. He's on dapagliflozin, 10 milligram daily, metformin, 1 gram Nocti plus an AC inhibitor. His blood lipids are well controlled, and he's currently on atorvastatin 10 milligram daily. His latest result of HbA1c was 7.9. His U&E creatinine showed result of urea 11, potassium was normal, bicarbonate 19, creatinine was 200, which was early stage of stage 2 chronic kidney disease, and his full blood count was essentially normal. His fasting blood sugar as at the time I saw him was 7.5. After reviewing the available therapeutic choices and his intention to fast for 1 month during the Ramadan period, what will be your advice? And do you think this patient should be allowed to fast? I'll give you just 2 minutes to respond on the chats, and then I'll give you an answer. I think the moderator should take in your answers in the next 2 minutes, and then I'll comment further. Can you hear me?
Yes, we can hear you, Prof.
Okay, thank you.
Prof, please, I think you should go back to case study 1 so that people can see and be able to pass comment. Thank you.
Or should I go ahead and answer the question?
Yeah, I think that's better. If people have answers, they might.
Somebody is raising her hands. I don't know. Should I just answer the question?
Yes, please.
Yes,
In
so
the
my
interest of
advice.
time.
Yes, so my advice on this patient is he has stable CKD stage 2, and the patient is on medications that he can take once daily, and he has never had an episode of hypoglycemia. So this patient, I will recommend him to fast, and I think he can go ahead and fast. So that's the first case. So let's go to the second case. This is a 55-year-old female banker who had hypertension for 3 years. She's a non-diabetic for 18 months. She had a history of hypercholesteremia and retinopathy. There was no history of microalbuminuria as of the time I saw her before seeing her results. She had no history of neuropathy or cardiovascular events, and she reports no cardiac symptoms. On diagnosis, she was initiated on metformin 1 gram twice daily, AC inhibitors, atorvastatin because she was obese, and she was advised to lose weight and have regular exercise. After follow-up every 6 months, she had an increased dosage of each medication, and her HbA1c remained at 8%. During the subsequent visit, she reported intermittent success with reduction of weight, but repeatedly she goes on to gain weight. For the past 6 months, she has been on these drugs, and additionally, she was given hydrochlorothiazide for her diabetes and lisinopril 20 milligram for the hypertension, and she was at atorvastatin and we gave her aspirin for cardioprotection. She reports taking these medications constantly. But the patient, after reviewing her, we found HbA1c to be 9, which has increased from 8, and her fasting blood sugar remained in the range of 163 milligram per DL, 150 and 170. She really never had controlled blood sugar. And her LDL cholesterol and triglycerides were within the target limit. She seeks advice as whether she can fast during Ramadan period. What is your opinion on her fasting for 1 month and the therapeutic option for her? So I advise this patient that I think she should not fast during Ramadan because her blood sugar control is not, she's not really controlled, and all the medication she is on, but her blood sugar is still not controlled. So advice here is patient shouldn't fast, but if she wants to fast, then she has to monitor her blood sugar at least 5 to 6 times a day, as the earlier speaker told us. So she has to be vigorous with blood sugar monitoring, and she has to know when to stop her fasting or when to break her fasting. The last case for the day is a 35-year-old male patient, known case of CKD that was diagnosed a year ago on conservative management. Although she's not a known diabetic, but she had a history of hypertension, which was diagnosed 2 years ago. She was currently on amlodipine and tolerates her medication well. She presented to the accident and emergency with history of loss of consciousness, 30 minutes, and had 1 episode of convulsion. On examination, she was ill looking. Her GCS was 5/15, and her blood sugar was 3. She was given 50% dextrose and maintained on 10% dextrose water, and we gave her IV paracetamol infusion. After gaining consciousness, then she admitted that she fasted on the day before her presentation, and she had 2 episodes of hypoglycemia during the Ramadan period. After reviewing her available results, we saw that her U&E creatininuria was 18, creatinine was 250, and her random blood sugar as of that time was 5.6. On discharge, she asked after discharge whether to continue her fasting the suspended days. What will be your advice? my advice was she shouldn't fast again, because already during the fasting period, she had 3 episodes of hypoglycemia and she had loss of consciousness and she did not have control in her sugar levels and she had stage 3 chronic kidney disease. So time for question and answers. Thank you very much.
Thank you very much, Professor Asha Tunalado, for your clear, concise presentation on diabetes and Ramadan, with particular emphasis on kidney diseases. So questions we'll be discussing later on. So thank you for keeping in time also. Now, the third speaker is Dr. Lambert Teta Opia. He is a practicing senior specialist physician, a cardiologist, and a researcher with interest in global cardiovascular health, including prevention, epidemiology, clinical trials, implementation science, improving health systems, and training. He works across the spectrum of cardiovascular disease in research on CVD risk factors, stroke, heart failure, HIV-related cardiac comorbidities. He also works as a senior lecturer at the School of Medicine and Dentistry of the Kwame Nkrumah University of Science and Technology, Department of Medicine. He completed his Fogarty Global Health Fellowship with the University of North Carolina. He's a fellow of both the West African College of Physicians and the Ghana College of Physicians, also a fellow of the International Society of Cardiovascular Disease Epidemiology and Prevention, and a member of the International Society of Global Health. He has a postgraduate certificate in clinical research from the Harvard Medical School. Currently, he is the General Secretary of the Ghanaian Society of Cardiology and the former organizing secretary of the society. So Dr. Lambert Apia will be talking on diabetes and Ramadan, with emphasis on fasting heart failure patients with and without type 2 diabetes. So Dr. Lambert, please.
Thank you. Thank you very much, Professor Chair, for the kind introductions, and also to the speakers before me, very eloquent presentations. Thank you, Astra, for inviting me to be part of this program. I think it's a very important topic. These are my disclosures. And this is my disclaimer. So on the menu for our discussion, it's basically a case study. We touch on risk stratification among heart failure patients, and then look at a couple of studies and some practical recommendations. I must say that previous speakers have done justice to the context of this presentation, which is Ramadan. Clearly, it's an important ritual in the Islamic jurisprudence, as we all can tell. And it is mandatory for healthy Muslims, with some exceptions that we have seen. Heart failure, again, is also a big issue across the continent, with varied etiology spanning hypertensive heart disease to ischemic heart disease. On the right-hand panel, you can see that the late Mayosi and colleagues looked at 2 time points and looked at the etiology of heart failure. You can tell that hypertension clearly rose up between the time frame 2007 and 2010. Again, cardiomyopathy did the same, whilst we recorded a reduction in rheumatic heart disease. This is consistent with findings in Ghana as well, where we looked at the trends in cardiac admissions. You can tell they are on the ascendancy, and closely mirrored by cardiovascular mortality. In that same paper, you can tell that what was driving the cardiovascular disease admissions was heart failure. So heart failure was constituted 88.3% of cardiovascular disease admissions. And this heart failure was largely as a result of hypertensive heart disease, as you can see on the right-hand panel. So clearly we interface with heart patients or heart failure patients, and I present one 70-year-old Muslim who I saw with gross peripheral edema and easy fatigability, slept on 3 pillows and had paroxysmal nocturnal dyspnea. Nothing significant in a family history related to cardiac diseases. The first time was in 2020. He had hypertension, diabetes, dyslipidemia, and COPD. I did an echo following the clinical diagnosis of heart failure, and clearly he had dilated cardiomyopathy with a very severely reduced left ventricular systolic function, ejection fraction of 25%. So this impression was made, decompensated dilated cardiomyopathy, likely ischemic, given his risk factors. So I had him on these medications, guideline-directed medical therapy, and he was able to afford them. Then I had to make some considerations. So as you agree with me, beyond treating the patient medically, you're also interested in looking at the underlying risk factor. So the suggestion was made to him for us to investigate for any coronary artery disease, but given his age, he wasn't keen to. So we had to optimize his heart failure therapy, given his lowest blood pressure. The question is, if this patient decides to fast, clinicians, what should we say or what should we do? And that would mean that we will need to risk profile these patients, as has been alluded in the earlier presentations. So is this patient moderate risk, low risk, low/moderate, high, or very high risk? So hopefully by the end of the presentation, we'll be able to classify such decompensated heart in terms of risk level. And again, once it's ascertained, that will inform the recommendation whether or not patient fast or whether patient can employ or resort to other alternative ways of. So the effects of fasting have been so much elucidated. I'd like to just drill down on the fact that indeed it reduces sympathetic tone, which is counterbalanced by increasing parasympathetic tone. So patients with reduced heart rate, respiratory rate, and blood pressure, which is one of the good things that the fasting does to individuals. Again, there's evidence to show that it improves cardiovascular markers. In terms of heart failure patients for fasting, it is on a case-by-case basis, because not any two patients are the same. As we all know, there has to be that kind of shared decision making. The clinician has a role, the patient also has a role. Again, it needs to be done. That decision needs, and suitability needs to be determined prior to Ramadan. It could be done weeks before the Ramadan. Again, when patients come to us within that context, it's important to take the advantage of routine clinic visit to at least profile these patients, so that when the question pops up, we will be for answer and give them the go ahead. Patients have comorbidities. Heart failure doesn't exist. It always or usually comes with comorbidities, and these impact stratification of such patient. Individual risk profile of patient also be borne in mind. So this document is by the British International Islamic Medical Muslims Association, or British Islamic Medical Association, I should say. The updated version, which was February 2023, has risk stratified patients into these three groups. So from the green is a low to moderate risk, yellow is a high risk, and then the red is very high risk. So needless to say, if you are in the low to moderate risk, we advise that you can go ahead with fasting. If you are in the high risk, which is yellow, you should not fast. And clearly, if you are in the red zone, you must not. So our focus is on heart failure patients. And indeed, if you are a heart failure patient with an ejection fraction more than 35%, or you belong to the category of heart failure with preserved ejection fraction, that is, your ejection fraction is at least 50% or more, and you are stable, i.e., at least for 1 month, your symptoms are stable, they haven't changed, they haven't worsened, then at least that patient can be considered for fasting. Again, if you have heart failure severe enough without advanced features, then we shall look shortly at what those advanced features or what we mean by advanced heart failure. Then such a patient should not fast ideally, but if he decides to fast or really wants to fast, then there has to be communication at risk to the patient clearly, and also there has to be management risk, which we shall look at. So heart failure is staged, as you can tell, or from the at-risk population to the advanced heart failure. So there's severe symptoms, signs and symptoms of heart failure at rest. There's recurrent hospitalization despite guideline-directed medical therapy. There's refractory or intolerant heart failure to guideline-directed medical therapy. Patients require advanced therapies. Transplanted patients may even require mechanical circulatory support. So these features will make a patient advanced or refractory heart failure, in which case the patient is precluded from undergoing fasting. So if you have a patient come to you, key questions to ask, as has been mentioned earlier: does the patient intend to fast during Ramadan? Does this heart failure fasting? If the answer is no, then you continue with the current therapy. But if it's yes, the patient then intends to fast, then the next phase is to risk stratify this patient. Is this patient low risk, high risk, or very high risk, as we have seen already? So if the patient is in the low to moderate risk, then the patient is allowed to fast. If this patient is allowed to fast, it's important to find out if this patient is taking his cardiac medications. If it's no, he's not taking those medications, and it's important to inform the patient of the risk involved in not treating your heart. If it's the case that the patient says yes, then the medications have to be optimized. The patient needs to be compliant, and patient has to be monitored. In the same algorithm, this patient who is being monitored, we've got to communicate the risk, the fasting or risk that may be associated with fasting vis-a-vis the heart failure patient. Again, if this patient's medication, we realize this patient's medications are not optimized and the patient is not compliant, it will, straight away graduate or shift this patient from the low to moderate risk to a very high risk, or to very high risk, I should say, which attracts the recommendation should not fast. The very high risk patient is debarred from fasting given the risk and prognosis. But if the case that the patient wants to fast, there are a couple of things that can be done. And this is something that I think is important, because some patients have very strong beliefs which they place above their health, and therefore some may still want to go ahead and fast. The question is, if they insist, we can explore alternatives of fasting or alternative options which may be safe. We could suggest on consecutive days, i.e., you don't fast every day. Maybe you could fast every 3 days or every 2 to 5 days. Again, we could also advise these patients to fast during the shorter day hours, which is usually shorter in winter than in summer. Again, for those who cannot fast completely, there's this ritual or spiritual compensation where they can provide food for some individuals in need. So in either ways, if you're low risk or high risk, we need to communicate the risk to the patient. The risk, whatever procedure the patient wants to embark on, whatever decision the patient decides, it's important to communicate the risk and the patient's risk and take opportunity to educate the patient about of the action. Again, if the patient decides to still go ahead, then we must to risk manage this patient. In addition to about the risk of dehydration that attends the period of fasting, issues with fluid overload, electrolyte imbalances that can engender the right environment for complications of heart failure to occur. These are risks that we need to monitor and manage appropriately. We must also consider medications and advise about sick day rules, i.e. if patient is on decides to fast and within the period, the patient develops an acute illness, it's important that the patient of his health or the condition that has emerged and fasting later if the health status would allow. Again, same for low risk, we still have to do risk management, and same we have to respect and hammer on. Must appreciate that you are fasting, but if you are down or you go down with some other illness, an acute illness, it's important to take care of that illness and then resort to alternatives. So specifically to heart failure, the data on it is very scanty, very limited, most of which are observational, and therefore is fraught with challenges like small sample size, lack of sufficient power to draw very strong conclusions. There's no data also on what close monitoring means, and limited data on diet of patients outside of the fast period. It's important that the heart will, for the most part, rely on fat glucose for its energy production. But during periods of fasting or intermittent fasting, ketone bodies become a better source of fuel for the failing heart. So energetically, failing myocardium seeks the ketotic environment engendered by the fasting and or the use of SGLT2 inhibitors. Recently, these have been shown to improve prognosis. So indeed, ketone body oxidation becomes the main fuel source for both phenotypes of heart failure. I want us to look at the schematic. Basically shows a rise in blood ketone bodies as you fast, and hence its utility in a failing heart described. A couple of studies to basically answer the question, does hospitalization for heart failure, congestive heart failure, does it occur more freely or frequently, I should say, in Ramadan compared to pre and post Ramadan? This involve mostly Qataris, and the conclusion is that this population-based study demonstrates that no significant difference was found in the number of hospitalization for heart failure while fasting in Ramadan when compared to non-fasting. Indeed, these patients were comparable in their age across the various times before Ramadan, Ramadan, and after Ramadan. And you can tell the hospitalization episodes were not too significantly different between the two groups. In terms of risk profile, those who were diabetic hypertensives were comparable across the group. In terms of medications were on, they were also comparable. ACE inhibitors in the 60% range, calcium channel blockers in the 50% range, and that order. So for the most part, though they were comparable, there wasn't a significant difference in terms of hospitalization for heart failure. Now, with chronic heart failure as well, suffice to say that the sample space was small, just about 250. It looked at if Ramadan had an effect on the symptoms of chronic heart failure patients. And this study concluded by saying that in most patients with chronic heart failure is considered safe. They realized, though, that non-adherence that are significantly associated with the compensation for heart failure during the period. So it behoves on us to really advocate for compliance and adherence to medications to reduce of decompensation. The Turkish Society of Cardiology consensus makes some recommendations which resonates with some of the things that have been mentioned already and some of the things that I have said. So all heart failure patients willing to fast should be warned of strict adherence to prognostically important medications and proper diet during fasting, as it can worsen the prognosis. Again, heart failure patients willing to fast should be evaluated for their medications, including their tolerability, and then titration of some medication downwards, particularly diuretics, given the risk of dehydration and its attendant electrolyte imbalances and deleterious effect on outcome of heart failure. Say, heart failure patient willing to fast, individualized examination to help profile these patients. Comorbidities have to be also assessed. Again, patients with less symptoms will do better, and patients who are in class 4 heart failure, New York functional class, should avoid fasting. I'll touch on some common medications in heart failure, particularly the current guideline-directed foundational therapy. So RASI, including ACE inhibitors, ANI, diuretics, corticosteroid receptor antagonists, SGLT2 inhibitor, beta blockers, all of these may compound the fasting-associated dehydration, particularly with resulting in acute kidney injury and or life-threatening electrolyte abnormalities. And when these abnormalities happen, clearly they would impact on outcome. Medication non-compliance, as has been shown, may result in hypertension, which most of these patients have, and also decompensation of their heart failure. So patients may also develop worsening angina, particularly if they default on their beta blockers and even some of their vasodilators. Again, if you are diabetic, you default on treatments like SGLT2 inhibitors, you may go into hyperglycemia, which may come with some complications. Medications like digoxin, again, the patient patients at risk of digoxin toxicity in the context of the dehydration that comes can be complicated by acute kidney injury, in which case digoxin is a potential threat. Vasodilators may also worsen the fasting-associated hypotension and may result in dizziness, and therefore these medications can be reduced or patient has to be closely monitored. Statins and their side effects can also be accentuated in the context of acute kidney injury and dehydration. So clearly, we need to do pre and post Ramadan checklist or reviewing of our patients. As has been alluded, it's important to find out the symptom status of the patient, smoking status, and use the Ramadan as an opportunity to embark on some smoke cessation program for the medical history. Very important. Investigation is very important to assess, and risk stratification, as we have mentioned. It is important to proffer this advice to like healthy diet, fluid intake. The fact that they can always terminate the fast if they feel well, and again, medication routes or routes for patients. IM injections and sublingual medication do not break Ramadan fasting, and patients can be given medications via this route. So this last couple of slides basically is just to drum home the entire that once we see patients, we are taking very important history, and we are focusing disease processes like heart failure, chronic kidney disease, which has been talked about, focusing on their lifestyle. We need to let them know that the Ramadan is going to come in dietary patterns, sleep patterns, and routine disturbances. And we need to appreciate the values of these patients that we see. Some clearly will have some preferences, some beliefs and concerns with compliance with disease medication or disease modifying medication during the period of fast. So all these must be borne in mind. Previous experiences with fasting has been mentioned already. Patients' medications important. Focus on diuretics in the context of heart important. All these will help to stratify the patient. Again, if the patient decides or to undergo the fasting, is important. Some patients may benefit from trial fasting, where they may want to fast for days prior to the Ramadan to see if it's something that works for them, and again to see they'll develop some complications which may prevent them from scale on the fasting. We must also advise or depend on location. As we know, geographical location and climate will impact on the length of the daylight hours. So clearly, once the shared decision has been made, it's incumbent on us to also mention safety issues that will happen once the patient decides to fast or not. Medication advice has to be given to this patient. Dietary, particularly in terms of rehydration, make sure that these patients are well hydrated, at least 0.5 to 3 liters, barring any contraindication. And again, let them appreciate the lifestyle changes that they are about to embark on. For folks who cannot undergo any of these, there are alternative ways of partaking somewhat in this fasting. There are charity endeavors that can be embarked upon, prayers, spiritual exercises that can be conducted. So, and to sum up, it's important to stratify the heart failure patient. Stable heart failure, severe heart failure, which is not advanced yet. This is a patient who is not on any ventricular assist device or any refractory heart failure. These patients, then you have to be careful and monitor them. Clearly, if you are in the green, your ejection fraction more than 45 or 35, then at least you can embark on fasting with monitoring. So in conclusion, risk stratification for cardiovascular disease generally important, and even more so for heart failure patients. High-risk patients are advised not to fast. Low-risk patients can fast during Ramadan. For fasting should be assessed individually. Pre-Ramadan clinical essential component, and we should take advantage of routine clinic visits to assess our patients even way ahead of Ramadan. It's also decisions that are taken are patient-centric. So shared decision, you tell the patient, you communicate the risk to the patient, and also communicate the management of those risks to the patient. Thank you very much, and thank you for your time.
Thank you, Dr. Lambert, for this detailed presentation on fasting and Ramadan, with particular emphasis on heart failure and other cardiovascular diseases. So now for discussion. So we have several questions in the and some in the chat box. So there are many questions to Dr. Sopala, about 4 questions. So I would give the floor to Dr. Sopala to answer some of the questions. So the first question is about extended release. I've seen them, so
I've seen them,
the
and
questions
I think
directed to you. You can go ahead and answer them, please.
Yeah, I think one of the questions that to me was related to autophagy, which I mentioned, right? And
yes,
these studies which are actually, there's studies which are actually showing that. In addition, like so auto just as regeneration of the body, and that's also related to intermittent fasting schedules that are there, and in a way that's like even their concepts related to aging and all, but I think the studies have not been done in Ramadan aspect as far as autophagy is concerned, like to delay aging, but then definitely we know that long term that could have a beneficial effect as far as but then there's, I think, another question related to the monitoring of blood glucose in Ramadan. And like I said, it really depends. So if your patient has type 1 diabetes, is on a basal bolus insulin regimen with multiple daily insulin injections, then that is a patient that you want to definitely advise to be checking their blood glucose 6 to 7 times that we talked about, as per the timings that I indicated. Patient is at low risk, and they're basically, let's say, either on lifestyle modification alone, or metformin and lifestyle, or metformin and DPP-4 inhibitors modification, then those are the patients that you might want to safely say that you don't have to monitor 6 to 7 times. If you can, well and good, but then if you cannot, or if it's difficult, and as per the, can even do 2 or 3 readings. So the most important readings, especially like in our parts of the world, you know that there's a lot of resource limitations as well. So you have to advise them wisely. So like, let's say if a patient is at low risk, then I can tell them at least, check on, even if it is alternate days, but try to check the most important is the fasting glucose, like before they break their fast, and the 4 p.m., like the before mid-afternoon glucose. That's extremely important, because that will guide you whether they're going in the tangent of hypoglycemia. And if the sugars are below, like let's say 5, I tell them to recheck again in the next 1 hour, so that we see if they're not going into the hypoglycemic range. Another important sugar reading probably would be the one before suhoor. That's another important reading to tell them to do. But what sometimes I say is do 3 readings on one day and 3 readings on another day, so that we get a feel of what's happening throughout the day if they cannot do all 6 readings. It depends. So then those patients falling in between moderate risk, depending on now what their risk of hypoglycemia is or risk of dehydration is, then you can tell them to monitor a bit more frequently accordingly. So it has to be quite individualized, with less frequency for low risk and higher frequency for high risk individuals. Of course, for those with CGM, you can monitor throughout the day. I think I answered the 2. Another important thing I'd like to say is, in addition to the benefits that we talked about, fasting is also shown to be for non-alcoholic fatty liver disease and obesity management, including even some neurodegenerative diseases, because of its role in improving your nerve growth factor release. So the additional benefits that it has shown to have. Thank you.
Dr. Sokwala, questions for you about metformin extended release. If a patient is on twice daily, do you need to change the dose? And the last one is about religious risk score recommendations are sanctioned by prominent Islamic sects.
Yes, so for extended release metformin, yes, you can change. If they're on twice daily, you can just switch it to suhoor and iftar. So they can take it with suhoor and with each dose, right? The other thing was about the Islamic. Oh, yes. So this is, if you look at the IDF-DAR guideline, it's actually highlighted in a lot of detail. And if you look at the religious aspect, there's a whole chapter on it. But there is actually science-stamped documents even attached to the guideline to show endorsement by the religious scholars. These are muftis primarily from Middle East and North American regions. North African regions, especially the muftis from Egypt, UAE, and the Southeastern Asian states. So yeah, definitely these have been endorsed quite broadly. I think the British Islamic Medical Association has endorsed the guidelines that my fellow colleague was talking about. And so these are endorsed guidelines, definitely, especially the IDF-DAR.
Okay, thank you. There are a few questions for Professor Ashatu. The first one is, will you advise your kidney transplant patient to fast?
Yes, actually, if it's a straightforward kidney transplant, because from all the literature I showed you, there are so many research that on patients that had kidney transplant, and all the patients were able to fast because usually it's their medication, and they use their medication twice daily, so they can take at sahur and iftar. So it's fine. If a kidney transplant patient is fine, his creatinine is normal, he's stable, then I advise him he can. But if he has complications, then you have to look into the fasting, or he's on several medication or rejection. He has some fear of rejection, then that patient should take his medication and not fast. But in as fast as he's stable and he's taking a twice daily medication, then it's fine. That patient would be advised to fast because the fasting will encourage him and it will help him, even if he has weight, it will help in his weight reduction, especially if he eats healthy during Ramadan.
And the other point that was raised was about the studies that you presented. And it's basically a comment that the small sample size, would it allow you to make, concrete conclusions? And another question is about past history of hypoglycemia. Would it negatively affect patients during Ramadan? And then in your first patient who is on metformin and dapagliflozin, isn't that patient at risk of acidosis and hypoglycemia?
Yes, so I will start because you asked them all first. First of all, I will start with which one did you say?
The first patient on metformin and dapagliflozin is risk of ketoacidosis and hypoglycemia.
There is a risk of that, but you have to be careful and outweigh the risk and know the blood sugar level of that patient. If you think that it's on metformin, if it's on 1 gram BD and you think you can reduce it to once daily dose, you can give him the DAPA, then I think it's fine. The only thing is make sure you monitor before Ramadan period, at least 2 weeks or 1 month, to see how his system is going to be, it's going to do without the fasting. And then with the fasting, you ask him to monitor his blood sugar at least 6 times a day. If you see he's at risk of going into hypoglycemia, then I think that patient should be advised not to fast.
Yeah.
The
good thing is about metformin and dapagliflozin, they have a very low risk of hypoglycemia if they are used alone without sulfonylureas or insulin. So as has been said, we need to monitor them, but at least for end up as a risk of hypoglycemia is really, really low.
And I think they can fast. So you just monitor. It's just self-monitoring that we should advise. And then the other question, I think she was trying to answer one of my case. She said, no, the patient should not fast. And I think I said that patient on case 2 should not fast. The other question is on what?
It's just a comment. Small size.
There was one of the study that has 1,129 patients. So if you can use that study, you can say it's generalizable. But really, you are right. This size so for you to say it's generalizable, I think then there's a limitation there. So that's why I advise on more prospective studies with larger sample size.
Okay, thank you, Prof. There is one question to Dr. Lambert. Why can't patients with pulmonary hypertension fast?
Thank you very much for the question. It's a very important question. I need to say that it's severe pulmonary hypertension. So you're talking about WHO functional class, maybe 3, 4. So these are patients class 3, for instance, less than ordinary activity, presents with marked dyspnea or limited function. And class 4 is basically at rest, you're having symptomatic. So this is as good as somebody who has heart failure or has symptomatic heart failure, in which case we don't even recommend them to fast. Again, patients who have severe pulmonary hypertension, pulmonary pressures, they may present to right-sided dilatations, of core pulmonary. These patients may be on some vasodilators, for instance, and for such patients too, you have to be very careful when they have the dehydration that induces hypotension in the context of vasodilator can even make their symptoms worse. So indeed, it is not recommended that they should fast because they are heavily symptomatic. Thank you.
Thank you so much. Edwin, if you could share, I don't see the chat box and the Q&A box. If you could share the screen. These were the questions raised so far. Are there any more questions?
I can't see more questions.
And then there are questions in the chat box.
In the chat box.
Yeah, I have addressed them, but some of the questions are about sharing the slides for the participants. I think Olanike, you could respond whether it's possible to send the slides to the. There were several people who asked about the slide, and some of the comments are appreciation for the presenters.
Okay, so thank you, Dr. Reja. Concerning sharing the slides, we would have to take approvals from the presenters if we can share the slides, because it's not within what we got approval for, so it might be difficult to answer that immediately.
Okay. So all in the chat box and in the Q&A box have been addressed. If you have questions, you can raise your hand, participants, because we have a few minutes.
Yeah, I think I can see one of the questions by Deladem Tamaklo. I think it's addressed to me. I don't know if you can see it.
No, I can't see the screen. Edwin, can you please share?
Okay, so
yes, I can see.
It says, Dr. Lambert, please, for practical purposes, in actual practice, how would you personally manage or handle patients who are classified as high risk but are bent on doing the full fast? Yeah, so that is a challenging scenario. But if you remember what I said, the two things are to communicate the risk and to do risk management. So if you effectively communicated the risk to the patient, chances are that the patient will decline to fast. If he still wants to fast, then you can do the fasting on alternate, days, or maybe every 3 days or every 4 days. Or you could suggest the option of spiritual compensation, where they give gifts and they feed individuals for every fasting day that is missed. Indeed, just yesterday, 2 days ago, I had two patients like that. One, their ages, one is 85, one is 60 plus, and the 60 plus had myocardial infarction and has had a stent implanted. So he for instance, is fasting, but I must say he's himself, so he's a bit informed, and we've had a discussion, and he's able to occasions between the 2 times of eating. The 80 plus, declined. He actually alluded that he because of his condition. So I think let's communicate the risk to them, and I'm sure they will make an informed decision. Thank you.
Okay, thank you so much. I don't see any more questions.
Dr. Reza, I think there was a case.
There's one.
There's a case also that was presented of a religious leader. I don't know if that was addressed by any of my colleagues.
No,
not yet, please. Not yet.
Yeah, so I think there's a question saying, please, I have a 65-year-old male, a religious community, was diagnosed with type 2 diabetes with peripheral neuropathy 2 weeks ago. He was 10.5%, hypertriglyceridemia. Patient is currently on metformin and glimepiride, atorvastatin, pregabalin. Now feeling better. FBS fasting blood glucose is 6 to 9, and pulse rate blood pressure is normal, and the advice on whether to fast or not. So if I can answer that, then I think the whole point comes down to just doing at least a risk stratification. You can see he's newly diagnosed. Most was diagnosed 2 weeks ago. We can see that was less than a year ago. HbA1c 10.5. So on the risk scoring, that is a high, I think a score of 3 or 2, I'm not sure. And then, so probably if you do the risk stratification of such a patient, it would fall somewhere around moderate risk category. And that's a patient that you can discuss with them, and they could potentially fast. They are willing to do their blood glucose levels frequently, as we have discussed. Because he's newly diagnosed, he is a patient I would recommend to check his sugar levels at least in the beginning, first 3-4 days, to check about if he can up to 6 times in a day. But if he cannot, then at least 4 times in a day. And then assess his risk and check whether he's getting hypos, hyperglycemia, dehydration risks, and all. And then if he's fine with it, then he could continue to fast, I believe. But if you have any of those issues, then you can discuss with them to either do alternate day fasting attempt or probably, the last 10 days. But it has to be on a case by do your risk stratification and advise accordingly. Unless my colleagues have to add anything to that.
Yeah. That's it. Thank you so much.
I think there's another question. There's a question on autophagy, and she said...
No, that has been already addressed.
But she asked and said, does it hold any marked benefit for patients with diabetic nephropathy or chronic kidney disease? The question in the chat.
Yes,
so
Doctor, would you like to reflect on it?
Yeah, so I would like to comment, because what she said is autophagy, it has benefit in patients with diabetes that are fasting, but actually the role of autophagy in patients with diabetic nephropathy or chronic kidney has not really been well established.
All right. Okay. I think we are coming to the end of our program. We had a fantastic attendance, over 250 people from Sub-Saharan Africa. I would like to thank the panelists who important aspect for our African doctors. And I would like to thank AstraZeneca again for this activity. And is at our doorstep, and it's important that we support our patients so that they can safely fast. So I hand over to Olanike. Thank you so much.
All right, thank you, Dr. Reja. So we've successfully come to the end of the meeting, but before we end, I would like to say a very big thank you to the panelists. A lot of work to make this presentation a success, and we appreciate how you have handled the program, the questions. We say a big thank you to every healthcare professional that joined. We really appreciate what you have done. It's nighttime in some of the region, and we know a lot of us have gone to work, and it's been a busy day. Thank you for the time you made out to attend this program. And we really appreciate you are putting in effort to do what's best for our patients. We hope that the patients will benefit from all the learning that we've taken away from this meeting today. And I won't stop at that. I want to say to all the commercial colleagues that helped to, but it's been a wonderful time having over 200 participants online. We appreciate all efforts put in place to get all our doctors to join. For the IT person, yes, you've been excellent. We really appreciate Saraka and Michael. Thank you so much. We had some recordings even before today, just as a backup, just in case the connectivity went wrong. We thank you so much for having us dropped off. It's gone on another thing. For the good management it's giving us as a team, and for my team members, Julia and Edwin and Sharon and every other. Thank you so much for the support you have given as well. And I would a good night rest to everyone. I believe we're all in the evening or at night. So this is it from us. Thank you from AstraZeneca. Rest.
Thank you, everyone.
Thank you and good night.
And good night. Thank you so much.
Good night. Thank you.
Recording